Today we have a special episode completing the series of podcasts on apical microsurgery. We want to discuss the workflow in endodontic microsurgery that why we couldn't find except that special guest who is considered as the best in the field. I believe that he is one of the few who is having the guns and powder in the topic, if you can understand what I mean.
Definitely, because our guest today is Dr. Fabio Gorni. So, hi Fabio.
Hi to everyone. It's a great pleasure to be here with you guys.
So, ladies and gentlemen, welcome to the 11th episode of Endocast, hosted by Ahmed Shauki. Hi Ahmed.
And by Francesca Ceruti. Hi, Francesca. So, in the beginning, when we discussed the workflow of the apical microsurgery, I guess our colleagues would like to know your perspective, Fabio, on the decision making before executing the surgery.
So the decision making is the first step, of course, of our treatment, and in theory, we should discuss for hours about that. Anyway, I know that for many guys, the first step is the non-surgical retreatment, but this is a big mistake in my opinion, because it depends on the level of the previous treatment. If the endo has been done correctly, so probably the non-surgical retreatment is not so predictable. So that's why we should decide in function of the success rates. And the success rate of the surgery is much higher compared to the non-surgical retreatment. This doesn't mean that we have to perform surgery all the time. So it depends if, for example, if we have to do some disassembling, removing crown, bridges, or something like that, post. So that's why sometimes endodontic surgery is the minimal invasive approach that we can choose.
Yeah, exactly. Perfect. So, Fabio, we know that in endodontic microsurgery, planning is of utmost importance. And we would like you to tell us how do you plan an intervention of endodontic microsurgery?
Plan the surgery is very important. The first thing that we have to check is the surgical access, because sometimes it's not possible to do the surgery because we don't have enough access in the back of the mouth, for example. Usually it's possible to reach without any problems the first molar, sometimes the second molar, but not all the time. The other things is very important is understand where is the lesion, only in the apical area or also laterally. Like in this case, the previous treatment is not so good, but in general, the patient got a crown recently, so that's why she doesn't want to remove the crown. It was a fully ceramical crown. So that's why we decided for the surgery. And in this case, I prefer to have a CBCT before, because the lesion is laterally. So I don't want to make a, a big apical resections. So that's why I want to discover first and the root, and make the root completely naked, just to check if laterally we can find a lateral portal of exit. So this is one of the reasons, because in my opinion, to predefine an apical resection is a big mistake all the time. It's very rare that we can predefine it, the apical resection. So that's why we have discovered step by step removing the cortical bone and then the woven bone and reach the root, and then we discover exactly the anatomy, and only after that decide for the apical resections.
Yeah, that was informative. And let me ask you about one of the most important steps in the workflow after planning, of course, and decision making, which is the anesthesia. What's your techniques and tools in posterior surgery for anesthesia? Because it also has an impact later in the procedure on hemostasis.
Yeah, I agree with you. The anesthesia is really, really important because we need to improve the quality of the bleeding control all the time during the surgery. So that's why we should inject the anesthesia just drop by drop, first in the shallow tissue and then only in the deep. And after that, wait some minutes before the incision, press the fornix with the gauze, and after 5 minutes we can start with the incision. So we need is in this kind of surgery is so important the bleeding control. Otherwise we cannot see anything. So that's the reason.
So, Fabio, you spoke about incision, and we know that the design of the flap and the reflection of the flap can have an impact also on the outcome of the microsurgery. So, I would like to know from you, how do you decide the flap design and how do you perform it?
So the flap design is really, really important, not only for the general success rate of the surgery, but also for the bleeding control, for example. The decision, it depends the amount of the attached gingiva in that area. And like in this case, for example, the attached gingiva is not enough. So that's why we decided for intracircular flap. In this case, is a papilla preservation flap. Uh, and the flap should be wide enough to facilitate the reflections, to facilitate the vision and the access. So that's why, and of course, also the reposition of the flap carefully because the stitches and the healing of the flap and the soft tissue, it depends of the precision of the stitches and the precision of the incision.
That's great. Apart from this case, because this is a maxillary tooth,
Yeah.
but when we reflect the flap in the mandibular premolar area, there is a specific area that creates a lot of panic to us, which is the mental foramen and the neurovascular bundle. So, what measures that you can advise to protect it during flap elevation and retraction, the mental foramen?
Uh, in my opinion, is a false problem. If you're able to do the surgery, it's not so difficult to identify the position of the mental foramen that usually is between the premolar. We have to check, of course, the position mesial to distal and coronal to apical. Sometimes it's so apical the mental foramen, so this is never a problem. When it's not so apical and close to the roots, we have to make an incision in advance, a couple of teeth if you want, and it's not so difficult to reflect the flap without any injuries to the mental foramen. When sometimes the mental foramen is so close to the apex, in that case probably it's better to make a notch in the cortical bone just to fix uh, our periosteal, for example. So the most the most damages that we can make on the nerve in when with the periosteal we push and push for maybe 1 hour in that area. So that's why we should have a very important fixed area for our periosteal, so just to protect our mental foramen. But it's not a big deal in general. I know that the colleagues are scared about the nerve, but is the last problem in my opinion.
Because you are very experienced, and so you can manage
So
it.
Fabio Gorni.
No, at the beginning of my career, I was not so skilled. So, and I never be afraid about the nerve, because my mentor explained to me exactly the real problem of the surgery that is in the job is not the nerve. It's never the nerve. Trust me, it's never the nerve. The problem is the interior part of the mandible, and not the nerve.
Very, very informative. Thank you very much, Fabio. And now let's switch to the hard tissue management. When the cortical plate is intact, so there is no lesion, how do you decide where is the starting point for your osteotomy?
It's exactly in the video that I'm showing. It's so simple. So we have to make some measurement on the X-ray, and then we can use the probe and check the length of the root. And after that, it's done. It's not so difficult. I know that nowadays so popular the guided surgery, but if you use the guided surgery just to get the target, it's fine. In my opinion, is totally useless. But for the beginners, maybe can help some. Uh, but it's there. The apex is there. Like in this case, is not a big problem. In this case, I'm using the piezo surgery for a simple reason. I'm not sure that in the lateral aspect of the root we will have a portal of exit. So I don't want to resect too much the root. So first I want to check the root, and only when the check is completed, I can decide for the apical resection. This is one of the reasons, in my opinion, the guided surgery is not so useful. Because we have to, the apical resection is a dynamic action. So we have to decide how to cut the root only in function of the anatomy and the position of the lesion. So many times we have to change the angulation of the resections uh, step by step, just discovering the anatomy, just discovering the problematic that we can have inside of the root canal system. So we cannot absolutely predefine the apical resection, in my opinion.
It's the same principle as the access cavity in orthotic.
It's exactly the same. Is exactly the same. Thanks, Francesca.
Yeah.
So the rationale for treatment is all the time is the same. In endo, the rationale for treatment is the same.
That's clear and straight to the point. I know you always prefer straight electric handpiece in posterior surgeries. Many of our audience would like to know why you prefer that. Maybe you explain the ergonomics about using this type of handpieces.
It's very simple, because only using the straight handpiece you can follow the action of the burrs. And it's so important to follow the action of our burrs, especially in the back, when, if you want to cut completely the root, for example, in the lower molar, sometimes we are very close to the lingual cortical plate. So that's why I cannot understand why some guys are using the angulated handpiece. Is absolutely not logical. Uh, in my career, I immediately started with the straight handpiece, because I learned endodontic surgery in Boston by Melvin Harris, and Melvin he used the straightened piece. So for me, it's not so strange. But I know that many guys are using the angulated hand pieces, but is nonsense in my opinion, because it's so important to check everything. And also in the video, you can see everything because I'm using the straightened piece. Otherwise, in some actions, the head
Block.
of the angulated straightened piece, we will occlude the vision completely. So that's why this is the reason. It's simple.
Simple and very, very rational as an approach. And another thing, we know that most of the times lesions are there because there is some missed anatomy. And so, how do you identify the anatomy of the apical third of the tooth once you have resected the root?
Using methylene blue, for example, then can help us a lot. Then we can clean everything with some saline, and well, the vision has been improved a lot. Now I can see two different portal of exit in the apex. It's a typical in this kind of tooth. Now I'm using a little bit of ferric sulfate just to increase the bleeding control, and now everything is clear, because now is the real part of the surgery that can change completely our success rates. Because endodontic surgery is an endodontic treatment through an osteotomy. So here is the focus of the surgery. This is not a surgery, it is an endodontic treatment.
Mhm.
Yeah. At this
Yeah, I agree.
More we will are precise in the cleaning, shaping, and the packing, and more higher it will be the success rate of our surgery.
Yeah. So I'm seeing something here that I'm been long waiting for asking about it, which is the bevel or no bevel. I know you have a different perspective about this issue, so maybe we will be interested to share this with our colleagues.
Uh, we are ready to publish an article for the end of the year about more than 500 cases of bevel or no bevel. Uh, if we bevel it a little bit, the root, we can see better what we are doing. So if we are seeing better, we will do better everything, each step of our surgery. So for many years, we discussed about that the probably the best apical recession was 90 degrees, but it's not true. It's absolutely not true. And I find that also another articles where other guys, they demonstrate exactly the same. So the bevel, also when the bevel is so important, so maybe 45 degrees, doesn't change anything in terms of success rates, but change a lot during your surgery, because you can see directly the anatomy, and you don't need to use, for example, a micro mirror to check everything. So if you can see you can use the micro mirror just to check inside of the root canal system if you want, just to check the quality of your cleaning. But with the 7-10 degrees of bevel, you can check directly with a direct vision everything, and trust me, is much easier to perform the surgery. Sometimes the bevel change completely also our possibility to save part of the root. For example, when the lesion is totally completely mesially or distal. So we can change the bevel following the lesion and save sound bone in the other part of the osteotomy. It's an interesting topic, and I hope to publish these articles very soon because it's one of the things that I strongly believe in the surgery. So we need the bevel. It's exactly the reverse that we discussed for years for nothing. Also because the reason to not do any bevel, it depends on the dentinal tubules that we open some dentinal tubules, but all the researches that are published about this topic are in vitro. So the difference between in vitro and in vivo is huge. So try to reach the same results in vivo is different. Trust me, it's different. So is following our motto feasible, teachable, and repeatable all the time is the same. We should try to simplify the procedure and not to be exactly the reverse. But for some guys, they love it. They love it to show something that is so complicated because sometimes it's so fashion. but
Trendy.
clinically is different.
Yeah.
Yeah, definitely. And since we are on the topic of controversial question, another one. In general, MTA is considered as the retrofilling material for after endodontic microsurgery, but we know that you are one of the few people that are in love with super EVA.
Not
So,
so few, huh? Not so few, Francesca.
well, I mean, in the literature, almost nobody says super
Yeah.
EVA over MTA. So, why?
Is because in the literature you cannot find any articles that show more success rate using MTA compared to Super EVA. It's so simple. So why I should use Super EVA that is more complicated to manage during the surgery compared to Super EVA? The question is simple. Have you ever read the bibliography? Yes or no? Because if you have read the bibliography, you know perfectly that it's impossible to find just one article, no, 10, just one, that show a different success rate using IRM, Super ABA, MTA, or bioceramic putty. So why I should use the most difficult material to manage during the surgery? I'm not stupid, so I'm trying to simplify any kind of procedures, also during the packing, because it's much easier to use Super ABA compared other material that, for example, sometimes, in this case, for example, the bleeding control is perfect. Not all the time is possible to reach this kind of control, and when it's not possible to reach it, is enough just a drop of blood that we are in trouble using bioceramic putty or MTA, and sometimes we have to restart completely the surgery from the beginning. It's a big problem, but I want just to underline one thing. That's a couple of guys that probably are guys that are doing a lot of surgery all around the world. Jean-Yves Cochet, Bertrand Caillat, they're using IRM. That is Super ABA. It's the same material. So if you want, you can use IRM. Super ABA is a little bit harder, so I love it. But I became crazy when we are discussing about gold standard, talking about MTA or other material, for example, bevel, no bevel. And you cannot find any evidence in the literature. So why we are discussed about something that is not true? Why? Because it's more fashion? I don't know. Or probably is more interesting for the commercial part because some brands are more interested to sell by ceramic putty or MTA. I love MTA. I started to use MTA in 1998. It's a fantastic material. And in some cases, I'm still using MTA also in the apical surgery, especially when we have a very, very large retrocavity. But 90% of the time, I'm still using Super ABA because it's more simple to use it and doesn't change anything in terms of success rates. Is it rational or not?
Perfectly.
Yeah.
It's rational, yes, absolutely. But if you
Yeah.
want to be more attractive for someone, if you want to be more fashion, use another material. It's not my problem
I think the only problem with Super EBA is uh,
to mix it.
to mix it because your assistant, I know them and they are smart. In other case,
I don't mix it. It's my nurse that mix it, and I have 3 4 nurses, and all the nurses are mixed the Super ABA very good. So it's not a big problem. No, trust me. Of course, if I use biceramic putty, of course, I take a little bit of piece of biceramic putty and I put the biceramic exactly on the top of the root. But try to condense the biceramic putty.
Will flow.
nice.
The three dimensional obturation is a must in endo in general. Besides, any kind of material are you using? I prefer, for example, to use MTA compared bioceramic putty because with the MTA I can condense it, and at the end I'm sure that the retrofill it will be three-dimensional. I don't want any void inside of my retrofill. And using BC putty all the time, I'm not sure because when you touch it, the materials is move up and down inside of the cavity, and it's a big problem in my opinion, especially when the cavity is more than 3 4 5 or more millimeters. It's not easy to condense, so I don't love it, but it's my problem. But if you want to discuss about the success rates, no articles that show difference in terms of success rate between IRM, Super ABA, BC Putty, MTA. And there are a lot of articles, huh? A lot. Clinical articles, of course. We are discussing about clinical articles, not in vitro. Because if we check the article in vitro, Super ABA leak more than MTA, for sure.
Mhm.
But we are discussing in vitro, in ex vivo. So try to reach the same results in vivo. I'm curious. Why never try to repeat this kind of research in vivo? Because it's too difficult. It's too difficult. In my career, I treated more than 2,000 lower molar, only lower molar, more than 2,000. So I started to do the surgery in 1988. I got a lot of experience, and I'm trying all the time to follow the easiest way. Of course, if the results are not good, I will change it. But the results are very, very good without any differences in terms of success rate between the new material and the old material. I started many years ago to using amalgam, and then I discard amalgam completely because the cements, with the cements, we can obtain better results and all the procedures are simple. It's simple in
That's
general.
yeah, that's very logical, and we should get back to the literature to see that really what you have said is true, because most of them are in vitro, and there is no difference in the clinical article between all these
Yeah,
procedures.
the literature is clear, but the problem that the guys they never read it. It's so simple.
So we asked a lot of questions, but it's an opportunity just to get information. So now we are reaching the end of the case, or the last thing in the case, which is very important in my opinion, which is the suture, the putting back the flap in its place and suturing. What the material that is are you using currently for suturing? And there is a very important question from colleagues, because they want to practice the suturing to excel it. So what's your advice also to them to practice the suture to be just like a brain surgery?
So the suture is important for the soft tissue management, of course, not for the final success rate of the endodontic surgery. But the final result, it depends mainly on the flap incision. When the
Mhm.
flap incision is precise, we can suture everything with a good precision. Um, Single stitches, you can use whatever you want in terms of material, nylon, resorbable sutures. Uh, Now, I prefer to use 670 resorbable suture, but it's not so important. Mm, what is really important is don't remove the sutures after 2 days, 3 days. Please, don't do it. Don't do it. Also, in this case, this is another topic where no evidence that you can improve the quality of your soft tissue management removing after 48 or 72 hours the stitches. Usually it takes 7 days, 10 days without any problems. And usually no scars, absolutely no scars. The scars, for example, many years ago, we discussed about to make an incision 45 bevel degrees to improve the quality of the connection between the two parts of the incision. Is not true. It's important that the incision must be very precise. That's it. After that, no scars at all. No scars at all.
Thank you, Fabio, because it was all extremely clear and straight to the point, and I think it's just in the spirit of the feasible, teachable, and repeatable idea that Style Italiano Endodontics has since the beginning. So I really want to thank you again for spending some time with us.
It's been a pleasure. Thanks, Francesca, and thanks, Ahmed.
Stay tuned for the next Endocast.
Bye bye and stay tuned.
Bye.
Bye.
Bye.